All right, we're back. This is Senate Health and Welfare, and we're joined by Senate Judiciary on a bill of joint interest, S-193. We do have folks in the room who can testify, and I think before we do that, because our questions about, we do want to hear from WellPath. Maybe we'll start with that.
Okay,
I'm going to kick you out again.
That sounds perfect.
With apologies.
No problem.
Karen, did you want to say anything before we move into the
No,
WellPath?
I'm here more just to answer questions. So I think it makes sense to go to WellPath.
All right, so WellPath is on the screen. Robin, thanks for being here. And do you have anything to say in the beginning, or do you looking to respond to questions?
You know, I could give an overview of WellPath and who I am, if that's a good place to start.
Thank you. Why don't we do that?
Okay, absolutely. So pleasure to meet you guys. My name is Dr. Robin Hodges. I am the Senior Vice President of Mental Health for WellPath. I'm a psychologist by training, and I've been with WellPath about 20 years, working between DOCs and jails. And I spent about 10 of those 20 years in the Maine DOC, so right next door to Vermont. I just wanted to give kind of a brief overview of WellPath for those who may not know who WellPath is. So we're a correctional healthcare company. We have about 42 years of experience in corrections. We provide services to 37 states across the country. We have about 300 partner facilities. We have about 8,000 plus employees. We serve roughly 148,000 patients a day. So around 8 million patient encounters annually, somewhere around there. And we organize our services for WellPath kind of around what we call our 5 Ps. So it's kind of our framework for excellence. So our top priority is patients. Patients are always first for us. Our people, so our team members. A lot of folks think because we're a Tennessee-based company, when we come into other states, we're bringing busloads of individuals. That is not accurate. We hire the folks who are in state. So for Vermont, we have hired and who are working in your facilities today, your neighbors, family members. We work with the community, and we hire folks in the community. And then our partners are critical. We have transparent collaboration with our partners. We're aligning our goals together, our processes. We have proven systems. We have continuous improvements, do a lot of CQI work, a lot of peer reviews, and our performance is critical. So measurable results, ensuring we have our accreditations. We as a company have never missed any accreditations. We've never failed any. We have quite a few what they call Triple Crown facilities out there, and we're accountable. So all that to say, we really sort of align our people, partners, processes around exceptional care for our patients to deliver really good, outstanding performance. So I'm going to bring it down just a notch, like what do we do in Vermont? And I never like to assume that folks know what Vermont DOC looks like because it's got such a unique system. It's a unified system. So you have sentenced and unsentenced individuals. Traditionally, folks who would be housed in a jail or in a DOC, they're all mixed together across 6 facilities, which creates a really nice, unique population in the state. We, as WellPath, have been the healthcare vendor since 2023. We were the healthcare vendor from 2010 to 2015 as well. And our scope of services is all healthcare. So medical, mental health, substance use, dental, et cetera. We manage all of the healthcare needs for the individuals who are currently incarcerated today in the state of Vermont. And then just a little bit about competency restoration, which is the whole reason I was asked to be here today. WellPath's got a long history of doing competency restoration. We are actually one of the very first private partners in California to partner with the Department of State Hospitals there to develop jail-based competency programs. And so we've got a long history of not only that, but operating in other states. And so we have a lot of experience coming in and working around whatever your statutes are. So I know you guys are kind of in process of that creation, but lots of different states have lots of different statutes when it comes to competency restoration. We're very fluid. We can work with any statutes out there, and we do today. They all vary in how they're delivered. I'm very familiar with Maine where we do competency restoration. But essentially what we do is once your statutes are really formed, we come in, develop your program, coordinate with your district attorneys, DMH, behavioral health, your courts, etc. And then we really sort of create an integrated program around psychiatric stabilization, legal psychoeducation, and assessment. Some states, their statutes depend. Sometimes they want the treating psychologist to do the evaluations, and sometimes they'll have an independent evaluator come in to do it. All states do it differently. Just kind of depends on where Vermont lands. And then obviously the whole reason WellPath got involved in competency restoration is the wait times for individuals in the jails were so long waiting on a state hospital bed that developing competency restoration reduced those waits for state hospital beds and also reduce the length of time folks were waiting to get to their court proceedings. So with that, I will take any questions. Hopefully that was helpful.
Yeah, no, thank you very much. That is helpful. And I think in particular, to some folks who are less familiar with the work that you've been doing within our Department of Corrections. So I do have a couple of questions. We are looking at S-193. It does place folks with mental illness or substance use disorder squarely into DOC. And our concern, obviously, here in health and welfare is that anyone who is placed in a facility who has a significant mental health issue, we'll start with that one. I know there's more work that's been done on substance use disorder than on mental health, but that anyone who has a mental health disorder is receiving the ongoing clinical care that they require. So in terms of the diagnostic procedures, some of the diagnoses will definitely be made outside of WellPath's purview, but then some of the treatment orders will be made outside of your your purview. These folks will need ongoing, consistent care. Can you talk a little bit about how someone who has I don't want to start with competency restoration. We've had a lot of discussion on that, but I'm speaking more from the perspective of bringing someone into a better state, a mental health state, and helping them achieve some level of capacity. So I shouldn't use that word. Mental health status. So someone who might require ongoing counseling, and you talked about wait times. That's a concerning phrase. So could you talk a little bit about how your organization deals and will deal in Vermont, providing mental health care for someone who has committed a significant crime and is in the care of DOC?
Absolutely. Yeah, likely we're already caring for these individuals today. We have a significant amount of individuals who are in custody in the Vermont DOC who do have mental illness. I'm not sure if folks are aware, but we have mental health units there. So we have both a kind of residential level and acute level mental health unit. We have staff assigned. All of our staff are licensed and credentialed individuals. Nurses.
I get that. I think I'm talking more about the timing and the number of counseling events that can occur. And if you have someone who's committed an egregious crime that is now being moved into this secure forensic facility, that's what we're talking about. So how are they being cared for?
So you're talking future state or current state?
Both. I think mostly future state.
Okay. All right. So future state, what for us is that we would obviously be working with them on a regular daily basis. So generally in different competency restoration programs, there may be a required treatment number that you're engaging with them daily. Perhaps that's a group daily, perhaps that's individual care. Some statutes are clear about that, others are not. But generally, for competency restoration, you're engaging with them daily through the milieu, through education, through medication compliance, because you'll have your nurses involved, psychiatry, mental health clinicians in general. And so you're caring for them much in the way that you would care for them in a state hospital, right? So there's the milieu going on, folks providing the treatment. Which is what happens currently today, is that individuals are cared for, they're seen regularly, depending on what their level of need is, depends on, everyone gets an individual treatment plan. And so depending on what that plan looks like, depends on what their treatment needs look like. So if they're in an acute mental health unit, they're being seen daily. If they have a stable mental health disorder, they're living in general population, they might be seen once a month, every other week. Just really depends on what the individual needs.
Senator Cummings, you have a question?
I don't know if it's a question or just the goal of this care. Competency rehabilitation, I think we understand. They go to trial. Okay. They go to trial, they're found, innocent by reason of insanity or mental incompetence. So they get sent to this facility or to the jail, wherever. We got in trouble with our state hospital, and we couldn't recreate it because Medicare, Medicaid won't pay for just maintenance. And so is the goal to cure that mental illness and restore people to competency? Or if the goal is just to keep them stable enough so they can live in a population, because last time I was on judiciary, which was quite a few years ago, there was concern about people in the correction system who had spent years in solitary confinement. They go to solitary, they come out, they do whatever they did that got them sent back. They'd be back for X amount of time, they'd come out. It was just a revolving door. Is the treatment we're talking about trying to make it so that people don't get caught in that kind of cycle? Or are we just having them seen by mental health clinicians to say they were, are we trying to cure them or make them better? Or are we just having them seen by a clinician to say, we saw, they got seen by 3 clinicians today, but nothing. How is it monitored? How do we know what we're paying for? I mean,
Right.
Was it judged?
Yeah, so what you're looking for is not necessarily the box check of they've been seen. Yeah, okay. If I can back up just a little bit, so how I sort of see this progression, obviously we've not had any specific discussions around how competency restoration may look in Vermont. So I'm going to just talk specifically about what information I have about other states and other programs to help answer your question. But essentially, when we have someone who is for competency restoration, so they've been deemed incompetent to stand trial, our goal is restoration, which is obviously the psycholegal aspect that may involve medication, but it also involves milieu. So depending on how we set up the program for Vermont, that can look like risk needs responsivity treatment, as well as, a lot of folks bring in good life. So it's not checking the box, it's actually working with people, problem solving, learning coping skills, learning about their mental health illness to better manage it. So our first task in that competency restoration is getting that individual to the point where they're competent to stand trial, or they're not. If they're found competent, keeping them competent through their court process. And then obviously, depending on what happens there, depends on where they go. If they're competent, they come to us for DOC because they're competent to stand trial. They're not going to get, is it NCR or NGRI for Vermont?
NGRI.
Thank you. Okay. I should know that, but every state operates so different. So if they're found NGRI, both are, regardless of where they come, if they're coming for NGRI or they're coming to live their time with us, it's all about getting them to the least restrictive point of care. So doing enough treatment to get them, if they're NCR or NGRI, getting them to the point where they could be reviewed for release into the community, right? So you're going to be treating them for their mental health issues, getting them stable. However, that's sort of going to look for Vermont if there's opportunities for them to visit the community, however it looks. If they're found competent and they're committed to us in the DOC, then they're still getting mental health treatment. Depending on how they're functioning will depend on where they live in our facilities, but they're still getting different types of group treatment, individual treatment. We're definitely not box checkers. So we have a great team in Vermont currently, led by our great regional psychiatrist, regional mental health director, medical director in general. And they are constantly looking at charts, reviewing cases. Vermont is a very small state, and so you have the luxury of having folks who are really oversighting and involved in those individual care pieces. And even at times, I'm involved in some of the care going on in Vermont because it's so collaborative.
So if you're involved, are you involved in person?
Sometimes I've seen, I'm licensed in Vermont, and so I have seen an individual in person when I've been there. A lot of times it's more remote. I don't live in Vermont, but I am licensed there.
Okay, so, and then I'll ask one more question because there's a hand up in judiciary and I want to get to that. How many providers do we have? Psychological counselors, mental health counselors do we have available in our state for the number of folks who require services?
You know what? I'm not going to guess. I oversee way too many states to give you a guess. Is that something I can send to you via Haley?
Yeah.
So I give you an exact number. I know roughly, but I don't want to misinform.
No, that's okay. That would be helpful. It's something that we've been, I get concerned about. When you say we're a small state, we also have workforce shortages that are significant within the general public as well as others. So it's
Absolutely.
and then I have other questions. I have a lot of other questions. Judiciary is here. They haven't had an opportunity to meet with WellPath, so I'm going to turn it to. It looks like Senator Wachowski has her hand up. I don't know which hand is up in judiciary, but I'm going to judiciary to ask your question.
Thank you. Yes, Senator Wachowski has a question.
I have a few. I'm wondering why the contract with WellPath ended in 2015.
I don't have an answer for that. I mean, in the correctional healthcare business, there's a lot of different companies out there, and contracts have to go out to bid X amount of years. So every time we get a contract, we're only locked in for X amount of time, 10 years, 5 years, whatever it looks like. And then it goes back out to bid, and sometimes folks may have a lower bid. It really depends. I don't know specifically why in 2015 Vermont chose a different vendor.
Okay, and how long is the current contract with WellPath?
I believe, and this will be another one I'll have to get back to you on, I think it's either a 7 or 10 year.
Okay. In your professional opinion, is prison a trauma-informed place for people to receive mental health care?
I think over the years, prison has gotten so much better about training folks in trauma-informed care. I could say probably when I first started in my career, we didn't really talk that much about trauma, and we thought about just women in particular. I think we do a much better job in more recent years training people on trauma-informed, having folks understand that this is just not about women. All of our clinicians are required to take trauma-informed care, CEs. We offer that through our program. So they're trained for trauma-informed.
But the actual prison structure, the concrete walls, the lack of lighting, the locked facility, the armed guards, is that trauma informed?
I mean, it's not ideal, but unfortunately it is the environment in which we exist in. So we try to make it as trauma informed as possible. Sometimes we paint so it looks less like a prison and more like a welcoming environment. We've done a little work at Chittenden over the years to make it a little more friendly. I mean, prison is prison, right? And so you can do some things, but you can't change other things. Other systems have changed, you know, how officers are dressed. So rather than having kind of that traditional looking uniform, they'll put on a polo shirt. So over the years, different systems have done things to try to compensate for things that we can't change, like the structure of the building, the doors, things like that.
Okay. And I know that there are about 1,500 lawsuits pending alleging negligence, abuse, medical malpractice, understaffing, and there's at least one in Vermont. But how many lawsuits against WellPath are currently pending in Vermont?
I do not know.
Okay. And do you know the status of the Chapter 11 bankruptcy filing?
That we are done with. We've emerged from bankruptcy, and we've been out, I think, almost a year at this point. And we're in great fiscal shape at this point. So that took, I want to say, approximately 6 months for us to get through bankruptcy and emerge on the other end.
Okay, thank you.
No problem.
Any other questions from judiciary?
No, no, thank you.
Okay, thank you. The folks around the table here in health and welfare questions. I know our concerns go very much along the lines of the questions that Senator Bohofsky was asking around having trauma-informed care and having a venue, an environment that is conducive to improvement and mental wellness. So I think you're hearing concerns that we have, and it's basic to the bill, of course. So we're not changing what the work that judiciary has done on the bill with respect to DOC. I know that institutions is also looking at the bill, and we're trying to find the best place and the best care that we can find for folks, regardless of the crime that they've committed. So I'm going to ask Karen Barber if you can respond to any of the questions that have been asked regarding contracting and length of time. I know we looked at it in justice oversight.
I'm happy to speak to the.
Please, yeah, that would be good.
For the record, my name is Kelly Summer. I'm the Director of Communications for DOC. Like Dr. Hodges stated, the contract with WellPath started July 1st, 2023. It is a 3-year contract, so it's set to end July 1st, 2026, with the option for two, I think 1 or 2 year extensions, but I can confirm that exact number.
Yeah, because as the discussion was going on, it was my thought that if we're moving into a new world, so there will need to be some contract changes to provide support for the folks who are not currently under that contract.
Yes, and one thing I would just note is that contract amendments are not just limited to the period in which a contract is being extended. We have made certain contract amendments throughout our contract thus far with WellPath for other emerging needs of care.
Okay, thank you. That's good. Was there any other question that was asked that wasn't answered that you can help us with?
I don't have the exact number of mental health care providers throughout the state in our 6 correctional facilities, but we can work with WellPAC to send that to the committee.
That would be really helpful. I mean, it's a great concern. If it ends up that we've got patients who are receiving only telehealth visits, that's problematic because the one-on-one contact is critical for care and improvement.
Understood, and appreciate the sensitivity as well around staffing challenges that persist throughout the state, to include for healthcare providers and correctional.
I know, it's a challenge for
Yes.
all of us. All right, other questions, Senator Cummings?
I'm just trying to clarify. This bill would set up a separate forensic facility in which we would house, and separate is at this point an undefined term. But it would be in some way removed from the general just criminal population. And it would house people who had been found either not guilty by reason of mental illness or incompetent to stand trial by reason. So they would be in a separate facility. We are not talking about housing people who had mental illness but had not come in contact with the court system there.
I see Katie also looking around, so I'll let you speak. I'm happy to speak to the infrastructure piece of it and then let you take the rest.
I'd
Or
like
speak now.
Yeah, let's counsel.
Katie McDonough, the legislative council. Sorry, I was concerned because I was seeing nodding on the screen. So there's nothing in the statute that says it has to be separate. The language and I shouldn't say statute, in the draft. The forensic facility definition means a locked facility or placement. But it doesn't say anything about that it has to be a separate standalone building or a separate unit. Those pieces could be added, but they're not there right now. So if there is an intent that's not reflected in the language, we should make sure that that language is updated.
So what are we changing from the present system? Right now, if you're in either of those categories, you are either in a corrections facility or you are up here in Berlin at the state hospital, right?
Or you're in a community facility. Could be in a community facility with 24/7
Which is not one.
care.
Yeah, but this would put people in community facilities in a locked facility?
Karen, we want to ask about that.
Yeah, so for the record, Karen Barber, General Counsel of the Department of Mental Health. So as we talked about it, like this is a gap in the system. So these are individuals that do not fit into the DMH system in terms of they're not eligible to be hospitalized. So they are not in our hospitals. They could be in corrections. That is generally time limited based on kind of their unique every criminal case is different. There is no other secure setting in Vermont outside of either DMH or DOC. So if they don't fit into those systems, they could be in the community. It doesn't necessarily mean they're in a community placement. They could just be in the community without supervision or a structure around them because those don't necessarily exist right now. So what we're attempting to do is for this very small, narrow population. So I think it's important to remember that we're only talking about folks that have been accused of committing.
How many people are we talking about?
We anticipate 3 to 5 a year. It's just a handful of people we're talking about. This is not anyone who is coming in through the civil system. And this absolutely does not mean that if someone has a mental health need in the community, doesn't commit or be alleged to commit a very serious crime and held without bail, that they would in any way be in a corrections system. They would go through the normal mental health system. This is just for that narrow set of folks that are accused of committing very serious crimes where there's not a secure setting for them currently.
Okay. Other questions? All right, so we haven't,
One sec, Senator Lyons,
Please
Senator-
go. Yeah, absolutely. It was my understanding from the testimony in judiciary that the plan is to use a wing at one of our prisons, so it will not be a separate facility.
there a question?
It's
for-
not, I mean, I know, I think Haley said that she would talk about the infrastructure plan, so it would be great if we could do that.
I was basically going to reiterate what Katie said, which was that it establishes the authority. There is not an existing forensic infrastructure outside of the correctional infrastructure that the state has.
So right now, these people would be in with the general criminal population, or perhaps, given the severity of the actions their mental illness causes them to take, these would be the people that are in solitary confinement a good portion of the time.
No, there are many details that need to be worked out, so we haven't designated exactly where that housing would be yet.
No, but I mean, right now, currently, these people are found incompetent to stand trial. They go to jail and get treatment until they are found competent, or they stay in jail unsentenced, or they've been found not guilty by reason of insanity, but committed to the correction system because they're a danger to the public, or did they get committed to the state hospital because they're a danger, or did they or they could just get put out in the street?
They could just get put out. Yeah, if they don't meet our criteria, then they would come into our custody. And as I said, that's the gap. There is no other system for them to go into. Once you're found not guilty by reason of insanity, you cannot, currently under statute, you cannot remain
Corrections.
in the corrections. This would allow someone who continues to have clinical needs and be a danger to public safety to remain committed until there was evidence the court found that they could be placed back into the community, that's the less restrictive setting, and that they are no longer a danger to others. But that does not exist now.
So the court has no option but to turn them back out until they do something else.
Correct. Unless they meet hospital level care, and then they could be in the hospital. But again, our hospitals are acute care systems. So someone only remains in the hospital until their mental health need is not
There's
acute.
hospitals like CBH, and there's the state mental health hospital.
So they are all licensed and run exactly the same. And just because someone is found not competent does not mean they're at BBCH. They could be at any one of our facilities across the state. Every hospital is run exactly the same.
Okay. And there's no locked facility. So they could walk out of any of those facilities anytime they want.
Inpatient units for involuntarily committed folks
Yeah.
are locked.
Are locked.
If they
So
elope,
would this
we
be
would not be
taking
able
such
to.
stress off our hospitals?
No, because these are folks that would not be in our hospitals. There are folks that are not eligible for our hospital system. Anyone who needs to be in a hospital will continue to go in a hospital. The idea is not at all to divert
So
people from the hospital.
I'm physically healthy.
Mhm.
But I'm mentally ill. And I have done violence to someone or something, probably someone. Found not guilty by reason of insanity. Right now, you're telling me that the only option a judge has is to turn me loose, or they could commit me to involuntary hospitalization.
If you meet that criteria. So there's two options, right? So if mental illness is the issue, but again, remember, this isn't just about mental illness. I know this is the only thing we focused on today, but we're also talking about substance use. We're talking about intellectual and developmental disabilities. We're talking about TBI and dementia. None of those things can be treated in the hospital. But if it is a pure mental illness, then you could be committed to the custody of the Department of Mental Health. And there are two ways that can happen. If you need hospital level of care, you can go to the hospital. But if you do not, then you would be put on an outpatient order in the community. So those are not secure settings. And so the gap, again, we're trying to fill is not just those mental illness with everyone, but the only real secure option is if you meet that hospital level of care. Otherwise, unless you meet River Valley requirements, you're
You
in
said
the community.
hospital level of care. I think a hospital level of care is I am physically sick. Not, my body is just fine. I can walk around, I eat, I breathe, I'm doing fine physically. My mind, on the other hand, has some problems. Are those, what do you mean when you say hospital level of care?
Sure. So all of our hospitals in Vermont are CMS certified and Joint Commission accredited. So that means that there are clinical criteria to be admitted to a psychiatric hospital. So just like maybe you broke your leg, but that doesn't mean you need to be inpatient, right? It could be that you need a lower level of outpatient care. It's the same with mental health. So what CMS is looking at is, do you have an acute mental illness? Can you receive active treatment? And is there no less restrictive alternative than to be in the hospital? So just like any other thing, if you could be served in an outpatient, you need to be served in an outpatient. And so only an admitting physician can make that decision. Those are clinical decisions. So a court cannot admit someone to a hospital. DMH cannot require our own hospital to take someone. Only a physician can make that clinical determination because it is a clinical determination.
So who would go to this new forensic facility? Would be a person who is mentally ill enough not to be competent to be found guilty, but not ill enough to require a hospital level of intervention.
So again, it's not, people are found incompetent and insane for lots of reasons
Yes.
other than mental illness. It could be mental illness. So it could be someone
But it
who
could also be substance abuse. It could be developmental delay.
So it's someone who doesn't belong in the DMH system in a hospital. So either that means that they do have a mental illness, but they don't need an inpatient level of care. They can be treated on an outpatient basis. And as you heard, corrections is already giving people an outpatient level of care, just like a DA would, right? Like those are kind of outpatient levels of care, substance use, all of the other things, right? So but the goal is to not this specifically in the language does not include people who need hospital level of care. So if they need to be in the hospital, they should absolutely be in the hospital. And the goal is for them to be there. But again, our hospital, unlike the old Vermont State Hospital, which was had lost its accreditation and certification at the end, people cannot remain in the hospital once they're no longer acute. And so it is not, we don't have long stays. We're an acute care system. And so just because even if someone were to go into the hospital initially, it doesn't mean that they would stay there. So this could be a discharge option if they no longer met that need, but still remain a public safety risk. And again, we're only talking about folks accused of committing
So
allegedly.
this might be someone who started out with some developmental delays and then fried their brain on drugs and wasn't going to get cured in a hospital setting, but was too much of a risk to be set loose on the general public.
The idea is that we are targeting individuals that are that have both clinical needs and public safety risks. And so the current system, because it's solely clinically based, doesn't have an option for that. And so we're really focused on how do we address both public safety and
So I think for clarity, we do have examples in the state, recent examples in the state where someone has been released into the community and has caused horrible suffering. And so we're trying to resolve that issue, but the best way to resolve it. So this is a proposal to solve that problem. So I'm going to go to Senator Clinton, and we're going to have to move on very quickly, but this is going to help me.
Just as I understand it, when you're making under your program, making a decision about an individual being admitted to a hospital, that individual risk of putting a offense, is not part of the process. It's their mental condition, not whether they're a danger to the public or not, in making the decision to admit them to the hospital.
It's a little more nuanced than that. So it's danger to self or others due to mental illness. But people can and do remain dangerous for reasons other than mental illness, or could have their mental illness treated to the point where they no longer need hospitalization. But that doesn't mean they couldn't be dangerous for other reasons. We see a lot of, especially with substance use, if someone has, their mental illness is treated, but if they use substances, it may cause them to be, engage in dangerous behavior. So we do look at danger to self or others, but it's only in the context of mental illness. Does that?
Yeah.
Okay, thank you. So here's what we're gonna do. We're not making any decisions right now. I know that the Claire Neal has sent some language that the agency has looked at relative to this bill based on conversations about we need to do the right thing, trauma informed and so on. Katie has a suggestion as well. So we need to look at this again. We'll do it next Tuesday when we're on outside of the umbrella of crossover week. Katie, do you want to look at your language now, or how do we want to do that? It's up to you.
I don't think my language is,
Not
perfect. I guess, it might be just worth thinking through how the instruction I got, or the concern I heard from this committee, is wanting to make sure that any placement was clinically appropriate and the providers were clinically appropriate. My first thought when I heard that was to put that as part of the definition of forensic facility in the bill. So I was sort of starting to work up in embedding those provisions within the definition of forensic facility. What you received from the departments is they're looking at rulemaking and having the clinical protections, for lack of a better word, be within a rulemaking process. So that's a policy decision, where you want to place those.
As you're talking, I think it makes sense to have it in both places.
Okay.
Go ahead.
No, I had one more.
Yeah, no, go ahead.
Food for thought. So we have been sort of emailing while you're having this discussion, because what is in the bill right now is emergency rulemaking, and what was sent from the agency is not emergency rulemaking, but the effective date of the forensic facility is July 126. And I was thinking, so are we operating without rules? And it sounds like there might need to be a change in the effective dates, because the intention is not to operate without rules, and the department wants time to put the rules in place. So that might be part of an amendment that you're looking at, is to bump out the effective date to give time for a rulemaking process.
Okay, we'll have to think about that. And then I asked Calista to put the agency's language up, and you've given your comment about the definition going in there. So we'll think about that over the weekend. And then the emergency rulemaking piece. The other piece is ensuring that the contract with WellPath reflects the needs that we have in the state for these folks. Understood. We've been talking about people who have committed a violent crime and don't have a place to be. But there are also people in this bill included with TBI, SUD, and we did mention IDD, so it could be that I don't know what role Act 248 is going to play. I mean, or the folks who have developmental issues. I have no idea what it is. I know. I knew that. So anyway, so there's a lot here that is specific by population. So different groups needing different levels of services. And we may want to reference that somehow in the rules as well. And does one place fit all?
I'm happy to work with Katie if that's helpful to chat.
Oh, no, definitely. We're going to have you work with Katie. But, my concern continues to be as, you know, we've talked about this in the past. We're trying to narrow this a little bit. Just to look at the folks who have committed a violent crime with mental illness. But I'm hearing from the agency that it covers everyone. We don't want to go back to covers everyone because then we have the Schaller method to take care of people with developmental disorders. That's the only way to help them. And we don't have a lot of people in the state who could take care of them. So I'm concerned that we're broadening the intent of the bill here. So I'm asking a question for you.
So the intent of the bill was to address,
I put the bill in, so
Okay,
I'm
sorry.
you
so
think the intent.
our understanding and talking with the state's attorneys and what we are hoping to address, what we see as the gap in the system is for individuals who have been found incompetent for any reason. And again, people are routinely found incompetent for reasons other than mental illness. So if you limit it just to mental illness, you're not actually addressing the gaps in the system. And a lot of some of the bigger cases you're seeing, they're not in the hospital because they don't belong in the hospital, right? So if the goal is to address the gaps, you have to think about more than mental illness. This is not purely a mental illness issue. Our goal is that very small gap. Again, we're only talking about individuals that are accused of committing the most serious crimes, but for whatever reason that they have been found incompetent, or for whatever reason they have been found insane, having a secure location where they can receive treatment and public safety can be a factor in their in their length of stay in that secure setting is what we are trying to address. My understanding was that the goal was to address that. That was to address the whole gap.
Intent.
And so it can't just be focused on mental illness because then you don't actually solve the gap.
And it also can't be just anyone who goes into a facility who has substance use disorder. Or anyone who happens to have a developmental disorder who's had a minor crime.
Correct. We're not talking about misdemeanors. We're not even talking about all felonies. We're only talking about very specific felonies that carry a life sentence, right? We are only talking about the most serious crimes.
Right. The judiciary's left, darn it.
Oh, okay. I was gonna.
That's all right. Okay, good. Thank you for that. So there will be something that Katie and you folks can work out. And we'll be coming back to this. Here's the problem. The bill was voted out yesterday. It's on notice today. It's up for action on Tuesday. We'll have to pass over it or we'll have something for third reading. That's a process I have to work out. And, but the latest that we can do anything with this amendment is Wednesday morning. So we're going to try and get to it. We're going to try and get to it on Tuesday. If we can't, we'll have Wednesday morning to finish it off. So that's how I'm going to present that to my colleagues in issue. Thank you for your time. And Robin, thank you for being here. Appreciate that. Very much. Okay.
Pleasure.
Go ahead. We're good.
I was just going to say, my pleasure. Thanks for having me today. I appreciate it.
All right, good. Thank you. So we're going to move on to two other bills. One is Michelle Child, but one is Katie's. So while Katie is here, we might move on to S-26.
Sure. Thank you.
Thank you. Since it's been years.
Yes, that worked on it for about a decade. So yes.
Oh, Michelle is here. Okay.
I am, sorry.
We just finished one bill that was Katie's and I didn't know whether we should go on to the other bill that Katie had or what's your time frame?
Can I just do like a super quick walk?
I have to do an email, so this works.
Go ahead.
Is that the one? Yes,
Yeah, no, I'm happy.
Sorry.
Whatever.
Got a
Good.
spicy debate on the House floor right now.
That's what I understand. So we have 239. Draft 2.1. Welcome.
Thank you.
All right.
So for the record, Michelle Childs, Office of Legislative Counsel, and we're going to look at the latest changes to S 239. Everybody should.
Senator Kulik is not able to stay on Zoom with us this morning, and so this is for. This was she and Senator Bohowski introduced it, so we'll make sure that she's okay with us. Well,
I can be with you till noon, so I mean till 11:30. I'm just in the car.
I apologize. I thought you said 11 o'clock. So good. Glad you're here.
I'll be listening.
All right. Terrific.
Having a little trouble with that. All right, and when we move from different places in the building, it disconnects and that's
It's okay. We move from bill to bill. We got the same problems in here. So it's good.
Yeah, we've got it. So we are looking at version 2.1 of the committee amendment with respect to the child abuse and neglect reporting working group. So I've highlighted the changes in yellow, and I'm just going to walk you through the changes. Thank you. Okay, so for the first changes in subsection A, and I just added the word mandatory reporting. So you had asked that it just be clear that we're talking about the mandatory reporting focus.
Right.
Subsection B are the folks who are on the committee. Sorry. And you'll see there's a change at the top of page 2. Previously, you had one member from the Department for Children and Families appointed by the commissioner, and the recommendation, I think, was for it to be 2 members, and those folks to be from the Family Services Division, so changed that. Then there's a new subsection C. And so you recall the testimony from DCF last time was that there'd be certain stakeholders that are kind of part of the process. And so typically what we do is just to kind of identify them as, and of course, the working group can be consulting with whoever is helpful for them, but sometimes it's helpful to specifically identify some folks who are stakeholders. So those are just the list of folks who were recommended by DCF. As well as a recommendation from Senator Minkowski for the Disability Rights Vermont to be on there as well.
So there's actually a total of 9 people on the working group.
On the working group,
Yeah,
right?
that's good.
Mhm. 9 people in the working group. So subsection D is your reporting requirement to January of next year. So there's some new language that I put under the reporting, and this is based on your discussions at your last committee hearing. So the first one is any recommendation should remain consistent with CAPTA, and then talks a little bit about what CAPTA is. The second one is to promote efficiency and avoid repetitive work. That the group is to leverage the work of the Children's Justice Act Task Force and the Vermont Citizens Advisory Board, which is something that's required by CAPTA. And then subdivision 3 is that the working group is to consider best practices from other states in developing its recommendations. Subsection E is that the working group is to have the administrative, technical, and legal assistance of DCF. And then a few little housekeeping things under that subsection is that they are to convene their first meeting on or before August 15th. They're to elect a chair at their first meeting, and 5 members shall be a quorum for purposes of what we just say. And that's it.
Good. Senator Gulick, your comments on the draft.
I think it looks great. Thank you so much, Michelle.
Questions, committee? Comments? Okay, I would entertain a motion on draft number 2.1 of S 239 as presented. Is there anyone up on the screen who wants to do a motion?
I'll move this bill move forward. Sorry.
Okay, so you're moving that S 239 draft 2.1 be voted on favorably and sent to the full Senate.
Thank you, Chair Lyons. That is my motion. Yes.
Well, so is it a different draft? It's 2.1?
2.1.
Okay, good. Good, we got it. She made a great motion. Discussion? Good, okay.
Okay, Senator Benson,
Yes.
Senator Cummings,
Yes.
Senator Gulick,
Yes.
Senator Morley, yes. Senator Lyons.
Yes.
5-0.
Is there anyone who would like to present the bill?
I'm happy to.
I thought that would happen. Good. Thank you, Senator. Appreciate it. I know you're busy with other bills next week, but this is a good one for you to do and I appreciate it. All right. Thank you, Michelle.
Thank you so much. And
Yeah.
anybody, please reach out if you have questions, or Senator Gulick, if I can help in any way with your preparation for the floor.
Thank you. Good. Good luck on the floor.
Thank you.
So we're going to move on to S26.
Okay.
This is great. They're accomplishing a great deal today. So S26, Katie, why don't you remind us where we are and we'll chat.
But under documents, open on this computer. Here we go. This is your bill on prohibiting certain artificial food dyes, additives, and foods sold at or provided at schools. I shouldn't say sold necessarily. The last time we met, we realized that the amendments had changed the bill, and the title of the bill specific to dyes no longer reflected what was in the bill. So you asked me to update the title of the section. So it's now prohibiting certain substances and foods and beverages served or sold at school. Also, last time we met, there was a list of 12 items. And number 8 and number 12 on your previous list have been removed. So now you have a list of 10 dyes or additives that are prohibited from sale or being served at school. And those are your only 2 changes. This is draft 4.1.
Okay. No, we reached out to the school folks. We made changes so that the agency will ensure compliance and will be responsible for the administrative oversights for this. And the 2 school folks that we heard from said that they still felt it was going to be really difficult for them to do. But then we also heard that the additives that are in here are being removed fairly quickly, and they're not sold in other countries, as we know, like European countries, Canada. So foods without these things are available. We also heard from the beverage industry, I think we all did, that some of the dyes that are in there and some of the additives are really important to the flavor of the beverages. But I'm not sure that the sodas and things that are sold that would contain those are actually sold, are part of the school food programs, so I'm less concerned about that. So, I mean, that's where we are with this one, and it's really a policy choice to keep it going or say, just let it happen naturally out there.
My only question is, I remember when we heard from the schools, that they had looked at the original list and said that really wouldn't affect their program, but they hadn't at that time looked at the additional items. And just when I haven't heard back whether they actually looked at them, or are they in their school program currently? Is that an issue or not an issue for them in terms of their program?
I don't think it's good. Go ahead.
I'm just thinking that there were a series of written testimony that came to the
Yes,
committee
We have.
from schools. And I didn't memorize them.
Yeah. That's why I just asked. this
We
question.
have it.
But
We'll look at it. I think we just, the schools did look at the changes that we made. Because we added in the second list.
Yep.
When we also reached out to Rosie Kruger, so I'm feeling that these are also. Okay, we will hear going forward. Now, we can find, I think we have some comments on earlier dates, so make sure we get all the comments up so that go.
Senator Lyons, can I ask a question, please?
Yes, please go ahead.
Did I hear you say that even with the new language that proposed by the AOE, that the folks in the field still think it's going to be an onerous process for them?
That's what they said. They said weren't sure that they could, that they thought it was going to happen organically, that these substances were being removed and that we should just let it play out, that it would be it would be burdensome for them. I don't think the word was overly. I'll make sure we have that testimony. It should be posted because we all got it.
So they think it's going to happen organically, but this is going to add paperwork for them to deal with. Is that right?
Well, the paperwork will be at the Agency of Education. We've removed that burden from them. Yes. Katie, help with the answer for that.
Sure. Hello. The language that was added, builds on an existing compliance structure that the Agency of Education was already following. That by reviewing school menus and product labels, I'm not sure what their time frame is, but they're already required to do that. And this adds to that existing process that they would have to be looking for these items when they're reviewing the school menus and product labels.
The school doesn't have to do it.
The school doesn't, the agency does.
The agency does that review.
That's the enforcement. The school would, to make sure they're in compliance with the bill, I'm sure they have to be checking them. But the enforcement is at the agency.
And when they find out they're not in compliance, if they don't meet the fine print, then the agency says you're not in compliance. And I'm assuming the agency can also say, here are alternatives, because that's what they're doing now. We've heard alternatives are available.
Right. I remember for the first group, they didn't feel that was a problem.
Right.
Then already most of it was out. There were substitutes. It was just, that's my earlier question, what about the others that were added?
That went to Rosie Kruger, my understanding. Went to like AOA. So it's part of the process.
I'm not sure where I am on this, though.
Oh, okay.
I think I'm gonna be a no, just FYI, as much as I support the thinking behind it, I'm not comfortable, right? I'm not comfortable adding administrative burden to schools when we're probably gonna be cutting their budgets.
Okay, let's offer some clarity. Katie, please. The role of the agency will be to look at the foods the schools are offering.
They're doing the formal compliance review.
So the agency is doing the compliance review. If they find that a school is offering foods, this takes effect in a year, July 2027. Doesn't take effect right away. But if the agency finds that a school is offering foods that contains one or more of these additives, then the agency will say, this food contains this toxin, this chemical. This is the alternative that you could put on your menu. So between now and 2027, we may see a reduction in a lot of these things because that's happening. So I know it's uncomfortable when we tell schools to do things. I know that. But I really don't feel uncomfortable about this. I think there's a process here that protects the individual school food.
I mean, at this point, I'm concerned that the AOE doesn't even have the capacity to do that little task because they are so overburdened, understaffed, and they just have a lot of issues right now. So I'm torn also.
Well, yeah, but AOE has testified they can do this, so I'm not gonna go behind the scenes on that one. If we need to put more staff in, put more staff in.
Rosie Kruger.
Rosie Kruger's on it.
Yeah.
Senator, Lilly.
I thought I heard that, I think it's from Burlington,
Yeah,
that they're doing this now anyways. So that they don't want to be getting products with these dyes, and that AOE could, their oversight say, hey, look, you're doing this. Can you try something else? And I'm sure that they would. I don't see a sports or anyone saying, yeah, well, we should be supplying more of these to our students. So I'm not positive that the bill is necessary right now. I may be completely wrong.
these chemicals are not chemicals that AOE is looking at. This would add chemicals that they look at. And they do have significant effect on development.
Okay.
Yeah, they affect all of us. I'm looking at it right there. Yeah.
But
Go ahead.
I think to your point, we're hearing that they are disappearing out of the food chain without any regulation.
Well, in Europe. Because Europe is outlawed. But they're not outlawed here. So supply and demand, some manufacturers may be removing them but some may have plants that feed market in the US. And maybe some schools are serving Fruit Loops, which I believe is one that's come under scrutiny for its beautifully attractive bright colors, which are better than light brown, supposedly. I don't think this is burdensome. I've had issues with, that was the federal government doing supply and saying you couldn't serve pickles or ketchup because there was too much sugar in it. and a football player got the same serving amount as
Right.
a 90-pound
Yeah.
cheerleader. That felt intrusive.
Draconian.
Yeah, but this one, I'm not having.
Oh, I missed something then.
Okay.
So the schools do want this, but
They don't want to have to go through all the labels and figure out if the state says, look, this product, next time they do your review, do you know down here in that tiny print, it says this chemical, and that's on the list. And you can't do that anymore. And here's the alternatives. Then I don't think that's, if they had to go through everything they served to try and find 2 more minute traces, or if we told them it couldn't contain more than 0.025%, that might be it. But as long as the state is saying, and they're not going to say you have to take it out. They've been doing this.
I know, that's why I'm.
Yeah.
Right.
So we're just telling them to do it with a few more chemicals.
And the agency will be providing the oversight for schools. Schools don't have to provide the oversight for these chemicals. The agency will look and see and say, these foods have these chemicals, and these are the replacement products that you can get. So I feel good about this one. This is nothing like what we've been through with some of the chemical discussions that
You haven't had.
No, No.
So it's about protecting kids. And it's not gonna happen organically unless their states actually push the federal government to push our manufacturers. There's only so much goodwill out there. Part of it is, right now, the European market, which is much larger than the market in the United States, and add Canada to it, is doing all this. So the products are available, period. They know how to put stuff together without these dyes.
Canada becomes the 51st state. It'll be outlawed in at least one state.
I like that. So anyway, there's a discussion. I did get a note from, I think that posted a message from, was it the superintendents?
Yes.
Yes, they're positive on this, very supportive of it. So it's not like schools are not supportive of it. Anyway.
Okay, I will support the bill, but I can tell you all that the AOE is struggling to support schools in many, many ways right now. So I am concerned that they will be able to do what we're asking them to do here, just because there have been other failures in other areas. But Senator Lyons, I hear your point, and I will support the bill.
Thank you, Senator, for that comment. And we'll move forward with a vote if we can get a motion. And then, come what may. I know there's a lot of work between here and the end of the day on this one. But I also hear you, Senator Drulek, and maybe we can work with, when education comes into appropriations, we're asking them about staffing needs, because it is an ongoing problem. You're right.
Has been for years.
Can I get a motion on this bill?
I'll move it. Approval, is it draft 4.1?
4.1.
Gee, I have to hit one basket. All right, favorably to the Senate. Okay, we've had a big discussion, so is there any further discussion? All right, Senator Clerk, keeping you busy today.
You are, I don't know what this one is, 6 or 7. Senator Benson,
Yes.
Senator Cummings,
Yes.
Senator Doolin,
Yes.
Senator Morley. Yes. Senator Lyons.
Yes.
So your last,
5-0-0.
That's good. I think this will be good. It
Yeah.
really will.
Yeah.
We'll sort it out.
the last comment, I think they feel much more
Good.
comfortable.
Thank you. Thank you, Katie. So who wants to report this bill? I have 3 bills. Who wants to report this one bill? Are you good?
Yeah, I'm good. I want to report it though.
Oh, okay.
I will if nobody else wants to.
Okay, Martine's got it. That's good. I like that. And you know about the school issue and school stuff, and we'll work on that. Agreed.
Okay. Thanks. Oh, but I can't bring it up because I'm not there.
So I'll bring it up for you
Just send
on your
it to you.
behalf. Can I sign it on your behalf?
Yes.
Okay. All right. Oh, boy, we have done our work. I know the S-194 is sitting out there. I'm looking at Amy. We're gonna work on that. I understand. It'll be a different way of putting that forward and getting that. And appreciate your work on it. All right, so we are calling it a wrap. Thank you for everything for crossover. This is,
Who likes you?
yes,